Second white coat. Subscribe and like. Let's learn medicine together.
Today, we are putting on our detective hats. We're diving into a case that's part sports medicine, part neurological puzzle. Our job, to follow the clues hidden deep inside the human body and crack a really fascinating medical mystery. So picture this. You're a college pitcher at the top of your game. Your arm is your ticket, it's everything, and then one day it just stops working. Not from some big dramatic collision, but from something quieter, something happening on the inside. That is the mystery we're unraveling today. What on earth could cause such a specific and devastating failure? Okay, so every investigation has to start with a case file, right? We need to get the basic facts down. Who are we dealing with, and what exactly happened? Let's open it up. Here's the rundown. Our patient is a 19-year-old college pitcher. He was throwing a ton of pitches during a tournament, a classic story of overuse. Super important, no previous injuries to his neck or arm. And now, he can't lift things, his arm feels weak, and part of it is numb. These are our first clues. All right, with the file open, the real investigation can get started. We're going to follow the findings from the physical exam like a trail of breadcrumbs. Every single symptom is a clue that's going to lead us straight to the culprit. So here's our first big piece of evidence. The patient has weak elbow flexion. Now, what does that mean? It means he has a hard time doing that classic bicep curl motion, bending his arm at the elbow. This is a very specific weakness, and that specificity, that's everything in a case like this. So as detectives, we have to ask the right questions. What specific parts of the body are in charge of that one particular action? If we can figure that out, we can start narrowing down our list of suspects. And boom, here's our answer. The two major muscles for flexing the elbow are the biceps brachii and the brachialis. And get this, both of them are powered by the exact same nerve, the musculocutaneous nerve. All of a sudden, we have our prime suspect. But hold on. Any good detective knows you need more than one piece of evidence to build a case. And our second clue is an absent biceps reflex. You know when the doctor taps that little tendon in your elbow with a hammer? Normally, your bicep jumps. His, nothing. And that, my friends, is a huge piece of the puzzle. See, the biceps reflex is basically a direct test of the whole circuit. And that circuit includes the musculocutaneous nerve. If that reflex is gone, it's like flipping a light switch and the bulb doesn't turn on. It tells you the problem isn't the bulb, it's probably somewhere in the wiring, in the nerve itself. The case against this nerve is getting really, really strong. Okay, we have a prime suspect. Now, to be absolutely sure we've got our guy, we need to understand everything about it. We need to know where it comes from, where it goes, and what it's responsible for. It's time to map out the anatomy of the musculocutaneous nerve. Now, nerves in your arm don't just pop up out of nowhere. They're all part of this massive, incredibly complex network called the brachial plexus. Think of it like a giant electrical junction box starting in your neck. It has all these stages, roots, trunks, divisions, and cords. And our suspect is just one of the final branches that comes off this whole system. Here we go. This is our crime scene map. It shows the nerve's exact path. You can see it branching off what's called the lateral cord of that plexus, and then it does something really interesting. It dives right through a muscle called the coracobrachialis. From there, it travels down the arm, nestled right between the biceps and brachialis muscles. This very specific route is a critical clue. So what's this nerve's MO? Well, it's got two main jobs. First, its motor function, which we already know about, is to power those muscles that bend the elbow. But it doesn't stop there. After it's done its muscle work, it keeps going and takes on a second job, providing sensation or feeling to the skin on the side of the forearm. And that leads us to the final symptom from our case file, the numbness. Knowing what we know now, that the nerve's journey ends as a sensory nerve for the forearm, we can make a pretty solid prediction. If this is the nerve that's injured, where would you expect the patient to feel that numbness? Exactly, the lateral side of the forearm, the thumb side. And this prediction perfectly matches our patient's symptoms. The weak elbow flexion, the missing reflex, and now this specific spot of numbness. They all point to one single culprit. Everything is lining up. But we're not quite done. Before we officially close this case, we have to be thorough. A good detective always considers other possibilities and rules them out for good. So it's time for the suspect lineup. First up, let's look at the radial nerve. If this nerve was the problem, you'd see weak elbow extension, so trouble straightening the arm. You'd also see a classic sign called wrist drop. and the numbness would be on the back of the arm. Our patient has the exact opposite problem. So, radial nerve, you're cleared.
Okay, next in the lineup is the median nerve. You might have heard of this one. It's the nerve involved in carpal tunnel syndrome. Its main job is controlling wrist flexion and thumb movement. Since our patient's problem is all about the elbow, not the wrist or hand, the median nerve is definitely not our guy.
The other suspects have solid alibis. The evidence against our prime suspect is consistent, it's specific, and it's frankly overwhelming. All the clues point in one direction. It is time to close this case and make the official diagnosis. So what was the motive? How did this even happen? Well, that classic pitching motion, that repetitive, violent overhead movement, can actually stretch that whole bundle of nerves, the brachial plexus. And the part that's most at risk? The lateral cord, which is exactly where our suspect, the musculocutaneous nerve, is born. It's a textbook overuse injury. And this right here, this is the ultimate cheat sheet for any armchair medical detective. It boils down the key patterns for each of the major nerves in the arm. If you can remember these simple connections, you can start to crack these kinds of cases yourself. And as you can see, our patient's symptoms fit perfectly in that top row. No doubt about it. And so, with full confidence, we can state our final conclusion. The diagnosis is a musculocutaneous nerve injury brought on by the repetitive strain of pitching. Case closed. So if you take one thing away from this whole investigation, let it be this simple formula. If you ever come across this specific trio of clues, weakness bending the elbow, a missing biceps reflex, and numbness on the thumb side of the forearm, you know exactly what nerve you're dealing with. And that kind of leaves us with one last thing to think about. Our bodies are this incredible, intricate network of very specialized pathways. This case shows how one specific motion can take out one specific nerve. It really makes you wonder, doesn't it? What other simple actions that we all do every single day without a second thought are literally hanging by a single delicate thread?